Gastric bypass is often called the gold standard of weight loss surgery, but what most people don't realize is what you're actually trading off to get those results. If you're trying to decide whether bypass is the right option for you, I'm a PA who has worked with bariatric patients for 20 years. This video will help you understand what life actually looks like long-term after the gastric bypass. In this surgery, a small stomach pouch about the size of a walnut is created at the top of the stomach. Then a portion of the small intestine is rerouted, so food bypasses most of the stomach and the first segment of the intestine. This change in anatomy is what gives the surgery its name. Food quite literally bypasses part of the digestive tract. Gastric bypass works through three major mechanisms, which is what makes it different from other bariatric surgeries. Mechanism number one, restriction. First, it is highly restrictive. The very small stomach pouch limits how much food can be eaten at one time, much more than the sleeve does. What this means in real life is you'll feel full with very small portions. Let me show you what this looks like in real life. This is half of a soda can, which can hold about 6 ounces and is filled with 2 ounces of solid food. For most patients, this is the maximum amount of food they can eat right after they reach the solid food stage of their postoperative diet. Patients get in adequate calories by eating 3 to 6 small meals a day. Eventually, the stomach enlarges somewhat and can accommodate closer to 6 ounces or half a soda can's worth of food. I wanted you to see this is normal because many patients are quite surprised at just how little they can eat at one time. Mechanism 2, hormonal and metabolic effects. Gastric bypass has powerful hormonal effects much more than the gastric sleeve. It changes how gut hormones involved in hunger, fullness, and cravings are released. Many patients notice a significant drop in appetite and a reduction in cravings, particularly for sugary or highly processed foods. Therefore, this is a great choice for patients who say sugar is their downfall. Mechanism 3, malabsorption. There is a mild degree of malabsorption, though this is not nearly as extensive as with procedures such as the SADIS. Because food bypasses part of the intestine, absorption of certain nutrients and calories is reduced. It's the combination of these three effects, restriction, hormonal metabolic effects, and malabsorption, that gives gastric bypass its reputation for strong and durable weight loss. Expected weight loss. On average, gastric bypass produces some of the highest weight loss outcomes among bariatric procedures, 30 to 35% total body weight loss, with the most rapid weight loss occurring in the first year. Weight loss usually begins to stabilize around 18 to 24 months when patients enter a maintenance mode. It's important to remember that these are averages. Individual outcomes vary based on biology, follow-up, and long-term behavior. Short-term surgical risks. Like all abdominal surgeries, gastric bypass carries short-term surgical risks. These include bleeding, infection, blood clots, injury to surrounding structures, and leaks at surgical connection points. Leak rates are low, generally around 2 to 3%, but because these can be serious, surgeons take great care inspecting and testing the surgical connections before completing the procedure. Overall complication rates are similar to sleeve gastrectomy, about 4%. The next part is the most important, and it's where I see people either do really well or struggle long-term. Important lifelong restrictions. There are also certain things that are no longer recommended after gastric bypass because they can cause injury to the intestinal connection points and lead to serious complications. These are not arbitrary rules. They are for your safety and directly related to how the anatomy is changed during surgery. Smoking must be stopped at least 6 weeks prior to surgery and is prohibited on a permanent basis after gastric bypass. This is because smoking significantly increases the risk of marginal ulcers at the intestinal connection sites, meaning it nearly always occurs if the patient smokes after bypass. This can cause bleeding, perforation, and require additional or emergency surgery and/or hospitalization. So you have to be willing to completely quit smoking before gastric bypass. Alcohol is also problematic after gastric bypass. Because alcohol is absorbed much more quickly after the surgery, patients can feel intoxicated faster with smaller amounts, and there is a higher risk of dependency pregnancy and liver injury. Also, intoxication normally leads to poor food choices, which derail health and weight loss. Alcohol also causes stomach irritation and can cause stomach discomfort and upset. For these reasons, alcohol should be completely avoided after gastric bypass surgery. Be sure to discuss this with your bariatric team if this is a concern for you. NSAID medications, also known as non-steroidal anti-inflammatory medications, should not be used after a gastric bypass. This group of medications includes ibuprofen, Advil, Motrin, naproxen, Aleve, and aspirin. These medications significantly increase the risk of ulcers and bleeding, especially at the intestinal connection points. If pain management is needed, your medical team can identify safer alternatives. Be sure to let providers know you have had gastric bypass surgery when they're prescribing medication for you. It's also advisable to greatly limit carbonated beverages, including sparkling water. Using straws and chewing gum should also be avoided. All of these increase the amount of air and gas entering the stomach. This can stretch the stomach pouch or intestinal connections, leading to discomfort, pain, or damage to these areas. And remember, these recommendations are about protecting the surgical anatomy, not about punishment. After a gastric bypass, daily multivitamins and routine lab monitoring are recommended. Deficiencies can occur if patients are not conscientious about their vitamin and supplement intake. This is why it's so important to show for your bariatric follow-up visits, so any vitamin or mineral deficiencies can be addressed and corrected early before they are significant enough to cause health issues. Long-term considerations. Dumping syndrome. Dumping syndrome is fairly common with gastric bypass. It occurs when sugary or high-fat foods pass quickly from the stomach pouch into the intestine, causing symptoms like cramping, gas, diarrhea, sweating, and weakness. While unpleasant, dumping resolves over time and can be managed long-term with dietary adjustments. Nutritional deficiencies are the most common long-term issue after a gastric bypass, more so than with the sleeve because of the bypassed intestine. Vitamin deficiencies that can occur include B vitamins, iron, calcium, and vitamin D, protein, which can be a serious risk if not enough protein is consumed, leading to muscle loss, weakness, and hair loss. Other possible long-term issues include gallstones from rapid weight loss, marginal ulcers at connection sites, and, less commonly, internal hernias. None of these mean gastric bypass is not a good choice, but they do mean you must understand and commit to long-term follow-up care. Gastric bypass can be an excellent option for certain patients. It is often recommended for individuals with higher BMIs, meaning BMI over 40 to 45, patients with metabolic disease, for example, uncontrolled diabetes, patients with significant reflux disease, those with strong sugar or carbohydrate cravings, people who are psychologically prepared to change eating habits, stop smoking, and take lifelong nutritional supplements, patients who have not had adequate results with another procedure. Just like the gastric sleeve, patients must be able to pass a physical and psychological evaluation. Because gastric bypass is a low-pressure system, it actually works very well to improve reflux, unlike the sleeve, which can worsen it in some people. That's why this procedure can be used as a treatment for reflux caused by the gastric sleeve or other issues. Gastric bypass isn't for everyone. Now, let's talk about what groups of people are generally not considered good candidates. Individuals with severe, uncontrolled mental health issues or active eating disorders. People who have unhealthy coping mechanisms, such as using food to cope with stress or significant events. Those who cannot commit to lifelong nutritional, dietary, and exercise changes. Patients with active alcohol or substance abuse issues. People who have unrealistic expectations regarding surgical outcomes or lifestyle changes. Those who have significant medical conditions that make the risk of bariatric surgery outweigh the benefits. Women planning to become pregnant within the next year, or those who are currently breastfeeding. Some patients may find these requirements too challenging or overwhelming. Therefore, if you have any of the concerns above, please be sure to discuss them with a bariatric surgeon who can give you personalized medical advice. Surgeon experience matters. An important factor with gastric bypass is surgeon experience. Complication rates are generally lower when the procedure is performed by surgeons with significant experience experience, often defined as at least 500 completed cases. This is one of the reasons choosing an experienced ASMBS bariatric surgeon is so important. ASMBS is the American Society of Metabolic and Bariatric Surgeons. Be sure to check the video description for a free printable PDF. It contains not only the top 3 questions you should ask a bariatric surgeon during your consultation, but also covers the details of the gastric bypass. I hope these videos help you feel informed and confident when you discuss weight loss options with your provider. If you're trying to decide between bypass, sleeve, or other options, watch the video pinned in the description. It'll help you compare them step by step. And be sure to subscribe because I release 3 videos a week that explain the professional weight loss world. I'm Grace, and this is Weigh In Wellness, where I provide safe, thoughtful, and fact-based information on surgical, endoscopic, and medical weight loss. Remember, this information is educational. I'm a physician assistant, but I'm not your PA. Decisions about treatment should always be made with your healthcare team. Thanks for watching, and I'll see you in the next video.